good analysis, and that's what they say to take over the concerns of early progression, IO chemo in specifically this subset, and Checkmate 9LA was this kind of trial actually. But before Checkmate 9LA was a trial of Checkmate 227, and there is a 4-year update of Checkmate 227, and to take us through that is Dr. Sanyo Dsouza. He's a medical oncology consultant at KMC Hospital, Mangalore. Dr. D'Souza.
Good morning, all. Thank you, Dr. Jatin.
Sir, I think network issue is slow from your side. You can switch off the video.
Can the organizers share the PPT, please?
Yes, sir.
Yeah. Yeah. So I'll be.
Yes, sir. You can start.
This Checkmate 227, that's Nivolumab plus ipilimumab versus chemotherapy as first-line treatment for advanced non-small cell lung cancer, the 4-year update. Next slide. So we know that NIVO and ipilimumab have distinct but complementary mechanisms of actions that when combined can prolong the long-term survival in patients with melanoma, RCC and non-small cell lung cancer as seen in recent RCTs. Nivolumab restores the anti-tumor function of T cells, while ipilimumab induces de novo anti-tumor T cell responses, including an increase in the memory T cells. So this phase 3 Checkmate 227 part 1 study previously showed that NIVO-EP significantly prolonged OS versus chemo in patients with advanced NSCLC regardless of PD-L1 expression or histology. That was published in NEJM in 2019 by Hellman et al. And this current analysis reports the updated 4-year results from this particular trial. Next slide, please. This is the trial what I'll be presenting, which was published a couple of months back. Next slide, please. So if you see the study design, it was a randomized phase 3 trial, and the median 50 follow-ups in recent trials. So the inclusion criteria with the patients with stage 4 or recurrent non-small cell lung cancer without known sensitizing EGFR alterations, no previous systemic treatment, and ECOG-PS of 0 and 1, no untreated CNS mets. 1,739 patients were randomized. There were 2 parts in this trial, that was part 1A and part 1B. Part 1A means those patients who had PD-L1 more than or equal to 1%. And part 1B included those patients with PD-L1 less than 1%. And if you see, the patients were randomized into 1:1:1 ratio into 3 arms. So the NIVO-EP arm, chemotherapy arm, and the Nivolumab monotherapy arm in those with PD-L1 more than or equal to 1%. NIVO arm was combined with chemotherapy, and the dosage of Nivolumab was 360 milligram every 3 weekly compared to 240 milligram every 2 weekly in the more than PD-L1 1% arm. So, and then the primary endpoints where there were dual primary endpoints, PFS in high TMB population, and another one was the overall survival in PD-L1 more than or equal to 1% population. Both of this was published in 2018 and 2019. And this particular study is the 4-year update. Next slide, please. Yeah, if you see the baseline characteristics, median age of around 64 years, smoking around 15% were non-smokers, around 30% were squamous cell histology. And if you see the PD-L1 status among in the subgroup with PD-L1 more than or equal to 1%, around 50% had PD-L1 more than 50%. But if you see in the combined, in the last column, in the combined PD-L1 population, in the NIVO-EP, among the patients who received NIVO-EP, around 30% had PD-L1 less than 1%, and around 70% had PD-L1 more than 1%. So next slide, please. Yeah, so this 4-year update gives us an updated OS and efficacy data with a minimum follow-up of 4 years. So we need to remember that patients were off immunotherapy for 2 years in this particular update, and it also gives us a comprehensive characterization of the safety profile of NIVO-EP. and also an analysis of efficacy in those who discontinued the NIVO-EP due to treatment-related adverse events. Next slide. Yeah. So the efficacy analysis in PD-L1 more than or equal to 1%. In NIVO-EP, 18% in the chemo arm, and the hazard ratio of 0.76. If you see the NIVO-EP, the OS curves of NIVO-EP versus Nivolumab monotherapy separates at around 12 months. And then if you see the OS curves of NIVO-EP and chemotherapy, they separate over time. In spite of the fact that patients in the chemo arm later received Nivolumab. This shows that dual immunotherapy is associated with the more durable efficacy. And if you see the median duration of response in the NIVO-EP arm was 23.2 months. Next slide, please. In the PD-L1 less than 1%, the median 4-year OS of 24% versus hazard ratio of 0.64 and the median duration of response of 18 months in the NIVO-EP arm. Next slide, please. And if you see the efficacy outcomes for PD-L1 in someone with more than or equal to 50%, the median 4-year OS was 37% in the NIVO-EP arm versus 20% in the chemo arm, and a hazard ratio of 0.66, and the median duration of response was around 32 months in the NIVO-EP arm versus around 5.8 months in the chemo arm. Next slide, please. Yeah, so this is a quite interesting. If you see the percentage of patients in response at 4 years, in the NIVO-EP arm, whatever the PD-L1, you see around 31 to 40% were in response at 4 years. If you see the PD-L1 less than 1% subgroup, the NIVO-EP arm around 31% were in response. But if you see the NIVO plus chemo arm, in those with PD-L1 less than 1%, around 13% were only in response, suggesting that this dual immunotherapy works quite good, especially in those with PD-L1 less than 1% too. Next slide, please. So if you see the safety, the treatment-related adverse events of any grade leading to discontinuation occurred in around 18% in the NIVO-EP arm. In the combined PD-L1 population, if you consider only the PD-L1 more than or equal to 1% population, around 16% had treatment-related adverse events leading to discontinuation. And the most common treatment-related adverse events leading to discontinuation in the NIVO-EP arm was immune-mediated adverse event was rash, which occurred in around 90% of those patients treated in NIVO-EP. Next slide. Yeah. So if you see the efficacy of patients discontinuing due to treatment-related adverse events, the OS in the PD-L1 more than or equal to 1% subgroup, the median OS was 30.6 months. If you see the 4-year survival was 44% in those who had discontinued the treatment due to adverse events versus 29%. And if you see the median duration of response after discontinuation was 52 months in the PD-L1 more than or equal to 1% group, and which was and the median duration of response was 34.2 months in the combined PD-L1 group. Next slide, please. So so this particular Checkmate 227 study showed that the NIVO-EP continues to provide durable clinical benefit with no new safety signals when compared to a platinum-based chemotherapy, regardless of PD-L1 expression or histology, as evidenced by the 4-year survival data. And discontinuation of Nivolumab ipilimumab due to treatment-related adverse did not negatively affect the observed benefits, which is suggested that which was seen that approximately one half of the patients with ongoing response for more than 3 years therapy sparing option for first-line treatment of advanced non-small cell lung cancer.
Thank you, sir.